Hey class, let's continue our discussion on the respiratory system. In this presentation, or this recording I should say, we're going to focus on some of the more nitty-gritty details. The previous recording that we did on this chapter, or on this body system, focused on the structural anatomy. So, without further ado, let's dive into the details. When we use the term ventilation or breathing, we are referring to, if we use this term ventilation, the movement of air. Now, as we breathe or as we ventilate, air is going to go in and out of our lungs. During inspiration, we have air going into the lungs, and expiration, we have air going from the lungs or out of the lungs. So inspiration means into the lungs, and then during expiration, we have exhalation. Now, to help you understand how we can have inspiration, expiration, we need to talk about some chemistry, particularly Boyles Law in chemistry. And Boyles Law is a law within the realm of chemistry that's closely related to the ideal gas law, PV equals nRT. But Boyles Law specifically talks about pressure-volume relationships. As the volume of a container increases, the pressure in that container decreases. So, here in this first part, we can see that the sides of this bag are being pulled out. The volume is increasing. And when the volume is going up, the pressure will go down. It is an inverse relationship. And because we have an area of low pressure in here, air moves in. Air is always going to flow from an area of high pressure to low pressure. I'll even write that on the screen. Air flows from high to low pressures. So by increasing the volume, we can decrease the pressure and make air flow into this bag. Conversely, if we squeeze on the sides of the bag and cause them to move inside or move towards the center and decrease the volume, so now volume is going down. In that situation, pressure goes up, and then air would be expelled. So during inspiration, when air is going into our lungs, our diaphragm is contracting, and this is the single most important muscle for contraction. The diaphragm, that's an important one. And the intercostal muscles are also contracting. As the diaphragm contracts, it goes from, if that was my rib cage, and our diaphragm is relaxed, it's arched up. But as the diaphragm contracts, it's flattened out and it goes down. And as that diaphragm flattens out and is lowered down, this is going to cause the volume within the thoracic cavity to increase. That increase in volume is going to cause a decrease in pressure, and as that pressure is decreasing, as that pressure is going down, that's going to cause air to flow into the lungs. So here's a much better looking thoracic cavity. Here you can see the rib cage, excellent photo of the rib cage. You can see the lungs within the rib cage, and when that diaphragm compresses or contracts and goes down, that causes the lungs to have more room, they take up more space, and the volume goes up, pressure goes down, and air will rush into the lungs. Expiration is the opposite. Instead of contracting muscles to increase the volume, we relax the muscles. And I should say that this process of relaxing the muscles is during quiet expiration. We can have forced expiration. That would be an example of coughing or sneezing. In those situations, we actually contract other muscles of the torso to force the volume of the lungs to decrease and force air out of our lungs. But if we look at it as a passive or quiet process, exhaling air, expiration, when we're doing it quietly or at rest, is a relaxing process. We stop contracting the diaphragm, we stop contracting our intercostals. That causes the diaphragm to go back up to its original position and the rib cage to move back towards its original position as well. The volume of the thoracic cavity goes down, the pressure increases. As our volume decreases, pressure increases and air rushes out of the lungs. So during quiet or at-rest expiration, the diaphragm goes back up again, and then the rib cage moves down and in, causing the volume to decrease, pressure to increase, and air to rush out of the lungs. Now, as we're breathing in and out, in and out, in and out, there are different volumes that we can move in and out of our lungs. The tidal volume repeats over and over again, kind of like the tides. It's the default change in lung volume. This is the amount of air that we move in and out with a gentle, relaxed breath. So right now, if you're watching this video, hopefully you're not actively running or not doing something that's physically strenuous. And if you're at rest, that small amount of air that moves in and out of your lungs is the tidal volume. Vital capacity is the maximum amount of air that you can force into the lungs. So you can have a small tidal volume, but as long as you have a big vital capacity, you can breathe really hard when you need to. Individuals that are physically fit or that are excellent athletes oftentimes will have a very large vital capacity so that when they need to, they can really increase the amount of airflow through their lungs. There are also going to be some volumes that we have left over. For example, if you are at rest and you exhale, you have your tidal volume that you exhale. If you need to, you can still cough. You could still exhale a little bit more. That leftover air that you can still exhale after you've had your gentle exhalation through your tidal volume is the expiratory reserve volume. Or let's say you're at rest and you're just sitting there and you breathe in a little bit, and then you decide that you want to breathe in a little bit more. That extra amount of air that you can inhale is called the inspiratory reserve volume. And then finally, we have the residual or volume of the lungs. This residual volume is the amount of air that must remain in the lungs. So let's say you try to push as much air out of the lungs as possible. You've exhaled as much as you physically can. There's still always going to be a little bit of air left over, and that is known as the residual volume. So let's look at a spirometer graph. So this is going to be in milliliters of lung volume. So in this graph, this typical lung has about 5,800 milliliters of total lung volume. Most of the time, our lungs will fluctuate between 2,400 and 2,900 milliliters of volume. This mild fluctuation is referred to as tidal volume. Now, after you inhale with your tidal volume, you can still inhale more. This range right here is referred to as your inspiratory reserve volume. And that's the extra amount of air that you can inhale. We also have some air that you can exhale after your tidal volume. That is your expiratory reserve volume. Expiratory reserve plus tidal volume plus inspiratory reserve. The total amount of air you can move in and out of your lungs is referred to as the vital capacity. And you'll notice that this graph never goes down, this line never drops down to zero. That is a good thing. If that line dropped down to zero, that would mean that we had a collapsed lung. But since it doesn't drop down to zero, there's always some leftover volume or air in the lungs. That leftover volume is called the residual volume. And if we combine the vital capacity plus the residual volume, we'll end up with a total lung capacity. To measure our lung volumes, we use an instrument known as a spirometer, which is shown right here. It's important to plug your nose when you use a spirometer. You don't want any air to go in and out through your nose. And then you can see this young child is breathing in and out through a tube, and this device is measuring the volumes of air that are moving past it. So, concept check class. The most important muscle for expiration is blink, whereas blink muscles are or is needed for expiration. We have abdominal muscle, 1, intercostal muscles, 0, diaphragm 2, diaphragm 0. So go ahead and rewind the video and get me an answer. Or you can pause it, check your notes, or the PowerPoint, or the textbook. Go ahead and get me that answer right now. 5, 4, 3, 2, 1. The most important muscle for inspiration is the diaphragm. And for expiration, how many muscles do we need for expiration? And that's a key word. Do we absolutely need? We absolutely need 0 muscles for expiration. So the correct answer is D, the diaphragm and 0 muscles. Moving on, let's talk about how we can control our rate of breathing. We can control our rate of breathing with our nervous system. There's some nervous control. Within our brains, we have a respiratory control center. And this respiratory control center is a region of the brain that controls how we breathe in and how we breathe out. Specifically within the brain, it is the medulla oblongata of the brain stem that controls this part of our bodies. It's been found that individuals that had suffered from sudden infant death, so SIDS, they died. This is thought to have occurred when this respiratory center in the brain stops sending out nerve signals. And in those situations, those individuals will stop breathing, and then they will pass on. This respiratory control center has also been linked to sleep apnea, where an individual will stop breathing in the middle of the night and then gasp awake because they start suffocating. Individuals that suffer from sleep apnea have been known to have terrible night sleeps because they're constantly waking up throughout the nights. So here we can see the brain. And within the brain, we have the midbrain, here's the pons, and then down lower would be the medulla oblongata. And in that medulla oblongata, we have the respiratory control center. And that respiratory control center is going to send information to the diaphragm and the intercostal muscles, particularly the external intercostal muscles. And that respiratory control center can send a signal to the diaphragm and to the external intercostals and say, hey, you need to contract. And as those external intercostals contract, the rib cage moves outward. And as the diaphragm contracts, the thoracic cavity moves downward. And that increases thoracic cavity volume, lung volume. And by increasing the volume, we decrease the pressure and cause air to go into the lungs, to inhale. And there's also some chemical control. We measure the concentration of chemicals in our bodies using a special kind of nervous system structure known as a chemoreceptor. A chemoreceptor is anything that can measure a chemical concentration in the body. We have specific chemoreceptors for pH, and for other blood gases, and for other blood ions. But pH absolutely is going to be directly linked to our rate of respiration. The single most important chemical, though, that controls our rate of breathing is carbon dioxide. More than anything else, the blood carbon dioxide levels will change our rate of breathing. As we have more carbon dioxide in our blood, the pH of the blood is going to become more acidic. So if we have an increase in CO2, that is going to cause an increase in blood acid, or the pH to go down in our blood. So by decreasing the pH and increasing the carbon dioxide concentration, and by measuring that with chemoreceptors, we can increase the rate of breathing. So if somebody has a lot of carbon dioxide in their blood, their brain is going to say, hey, you need to breathe in and out more. You need to get that extra carbon dioxide out of your bloodstream. If somebody has a pH that is too acidic, the brain is going to tell them, hey, you need to breathe in and out a lot more. We need to change that and remove the acid from your bloodstream. As we are breathing in and out, within the alveoli of the lungs and at the tissues of the body, we're going to have gas exchange. Oxygen and carbon dioxide gases are going to be exchanged. In the lungs, we put oxygen in the blood, and then at the tissues of the body, we pull oxygen out of the blood. This exchange of the gases is going to be highly dependent on diffusion, which is the movement of a chemical from an area of high concentration to an area of low concentration. So if we look at the partial pressures of these gases, if there's a high partial pressure of carbon dioxide on one side of a membrane, so if we have a high PCO2 on one side of a membrane and a low PCO2 on the other side of the membrane, what is going to happen is carbon dioxide will move with its concentration gradient. It'll go from the area of high concentration to the area of low concentration across that semi-permeable membrane. And the same is true for oxygen gas. If we have an area of oxygen gas where there's a low PO2 and an area that has a high partial pressure of oxygen. You can think of partial pressure as a way of measuring a gas concentration. Then the oxygen gas will go from the area of high concentration to the area of low concentration. As these gases are exchanged, they'll diffuse across the membranes of our body based on their concentration gradients. In our lungs, we will have external respiration because the blood gases are being exchanged with air from the external environment. The PCO2 in the lungs is very high in the blood going to the lungs. There's more carbon dioxide in the blood going to the lungs than there is in the air that's being inhaled in the lungs. So in those situations, carbon dioxide will go out of the blood plasma and into the alveoli of the lungs with its concentration gradient. And then we exhale the carbon dioxide. On the other hand, the blood that's being sent to the lungs has a very low concentration of oxygen. So oxygen will go from the lungs to the red blood cells. Oxygen will enter the bloodstream in the lungs. Again, oxygen is moving with its concentration gradient. Now, if we look at this figure, with this slide tells us how we move those gases through our bloodstream. In our red blood cells, within our red blood cells are RBCs, also known as our erythrocytes. We have many hundreds of millions of proteins known as hemoglobin. Approximately 300 million hemoglobin molecules per red blood cell. And we abbreviate hemoglobin as HB. Each hemoglobin can attach to 4 separate oxygen or O2 molecules. And as hemoglobin binds to oxygen, we call it HbO2. So we move oxygen on the hemoglobin within the red blood cells. Carbon dioxide, on the other hand, is not going to be moved primarily in the red blood cell. Most of our carbon dioxide is going to be moved through the bloodstream as carbonic acid. So the cells in our bodies make carbon dioxide. That carbon dioxide is combined with water, and this enzyme, carbonic anhydrase, can power a double-sided reaction. So in the tissues of our body where there's high concentrations of carbon dioxide, this enzyme, carbonic anhydrase, will turn water and carbon dioxide into carbonic acid, which will then rapidly diffuse into a bicarbonate ion. Most carbon dioxide is transported or moved as bicarbonate ions in the blood plasma. And we covered that and emphasized that in extreme detail when we covered the blood as part of our cardiovascular system. So this figure does a great job of summarizing the process. In our lungs, where we have external respiration, we are going to have bicarbonate ions going into the red blood cells and being turned with carbonic anhydrase back into CO2, which then diffuses into the alveoli of the lungs and then is exhaled. On the flip side, we're going to have oxygen gas going from the alveoli of the lungs into the red blood cell and binding to hemoglobin. In those situations, we inhaled and absorbed the oxygen. And then the opposite occurs in the tissues of our bodies. Deep down in the tissues of our body, where there's low oxygen concentrations, oxygen will leave the hemoglobin and then diffuse out of the red blood cell to the tissues of our bodies. And on the flip side, carbon dioxide will go from the tissues of our body into the red blood cells and be turned into bicarbonate, and then the bicarbonate is going to be transported in the blood plasma. During internal respiration, we have the opposite of external respiration taking place. External respiration takes place in the lungs. Oxygen enters the blood, carbon dioxide leaves the blood. Internal respiration takes place between the blood and the tissues of the body. and it's opposite of external respiration. During internal respiration, we are going to have oxygen leave the blood, it diffuses out of the blood, and carbon dioxide diffuses into the blood. So if we back up a slide here, this is all external respiration on top, and then on the bottom, we have internal respiration. And in those situations, during internal respiration, oxygen leaves the blood, or leaves the hemoglobin, and is sent into the blood and then goes to the tissue. And during internal respiration, carbon dioxide is going to be combined with water to turn to bicarbonate ions, or to carbonic acid, which then turns into a bicarbonate ion. So if we were to back up a couple slides here, on this slide right here, I emphasized going from the right to the left, going this direction. Going that direction from the right to the left is internal respiration. During external respiration, though, we go from the left to the right. So during the external respiration process, we are actually going to add oxygen to the hemoglobin. And during this external respiration, we can take bicarbonate from the blood plasma and turn it into carbon dioxide that we exhale during external respiration. So, class, concept check. External respiration takes place between the blink, and internal respiration takes place between blink. Is it lungs and blood, blood and body tissues, blood and blood, body tissues and body tissues, or lungs and lungs? Get me an answer. Go ahead and rewind the video, pause it, check your notes, check your textbook. Get me an answer, please. 5, 4, 3, 2, 1. External respiration takes place between the lungs and blood. And then internal respiration takes place between the blood and tissues. So our correct answer is A. Lungs and blood is external respiration. Blood and body tissues is internal respiration. Moving on, let's talk about some homeostatic imbalances that can occur, or some disease states that can occur. Here are some upper respiratory tract infections that are fairly common. You can have sinusitis. Sinusitis is an inflammation. Look at this itis. Itis for inflamed. Sinusitis is inflammation of the sinuses. And usually when those sinuses become inflamed, they become blocked, and a patient will have a painful sinus infection. Sometimes there'll be otis media. Otis media refers to the bones of the middle ear. And if somebody has otis media, there is an infection in the middle ear, sometimes just commonly referred to as an ear infection. Young children have a eustachian tube, or a tube that drains the middle ear, that's very horizontal. There's not a good pitch to their eustachian tube, so young children have an increased risk of ear infections. Adults have a lot more inclination, or a steeper pitch to their eustachian tube, and it's easier for an adult to drain their middle ear, so they have a decreased risk of otis media, or ear infections. We can have tonsillitis, inflammation of the tonsils. This is typically going to be characterized by difficulty swallowing and difficulty talking. And then we also have laryngitis. This is inflammation of the voice box and is absolutely linked to difficulty talking and can sometimes be linked to temporary loss of your voice. Some infections that can occur in the lower respiratory tract include pneumonia, tuberculosis, and pulmonary fibrosis. Pneumonia is characterized as a buildup of fluid in the lungs. So the lungs are becoming clogged with fluid, and those alveoli are no longer able to be filled with gases to have gas exchange occur. Tuberculosis is caused by a bacterium known as Mycobacterium tuberculosis, and this bacterial infection leads to tubercle formation. A tubercle is a collection of encapsulated bacteria, and these bacteria are very difficult for our bodies to destroy. We also have pulmonary fibrosis. This is going to lead to the buildup of fibrous tissue in the lungs. In other words, we effectively have scar tissue buildup in the lungs, and as the lungs have scar tissue building up in them, the lungs lose elasticity, and as the lungs lose elasticity, the patient has difficulty exhaling. So if during pulmonary fibrosis, exhalation is hard. In order to exhale, the patient needs to push the air out of their lungs by contracting their internal intercostals, their external obliques, and their rectus abdominis. It's a lot more work to exhale. In a healthy pair of lungs, instead of pushing the air out, we just relax, and the elasticity of the lungs will take over and move the air out. Some other lower respiratory tract infections also include emphysema. Emphysema is characterized by having damaged alveoli. And the alveoli will burst and fuse together. And as these alveoli fuse together, there's a decreased area for gas exchange. So the surface area is going to be reduced. And if there's the reduced area for gas exchange, we don't have the ability to put as much oxygen into our blood. If a patient has asthma, their bronchial trees, so their trachea, primary, secondary, tertiary bronchi, and then their bronchioles become irritated and swell shut, or swell and reduce the diameter of their openings. In severe cases, they do swell shut. And that causes the patient to feel breathless, for there to be wheezing and lots of coughing, and it's a very painful condition. And finally, we have lung cancers. Any cancer is characterized by an uncontrolled growth of body cells or uncontrolled cell division. Lung cancer in particular is linked to uncontrolled growth of cells that are normally present in the lungs. It has been strongly linked to smoking and will often cause death in the patient in a very short period of time. Here's a slide that sums up those respiratory diseases of the lower respiratory tract. Pneumonia is when the alveoli fill with fluid. Pulmonary fibrosis is when we lose lung elasticity. Tuberculosis is when the lungs are filled with tubercles. Emphysema is when we lose surface area and the alveoli burst. Asthma is constriction or inflammation of the bronchioles, and bronchitis is inflammation of the bronchioles and the buildup of mucus in those bronchioles. It's worth emphasizing that all forms of tobacco cause damage to the human body. That includes snuff, chewing tobacco, and smoking, whether it's pipe, cigar, or cigarettes. Smoking in particular increases the chance of lung cancer, esophagus cancer, bladder, kidney, stomach, cervical cancers. In other words, smoking is just terrible for you. It's going to really increase the risk of many different kinds of cancers in your body. It's also going to increase the risk of chronic lower respiratory diseases and stillbirths in pregnant women, and causes a lot of harm to unborn children. So don't smoke if you're pregnant. If you are a woman who becomes pregnant, use that as a catalyst to stop smoking, or at least take a 9-month break from smoking. Even secondhand smoke, so passive smoke, can increase a non-smoker's risk of developing many of these respiratory tract diseases. And because medical marijuana is on the rise and recreational marijuana is becoming increasingly popular, I went to the American Lung Association's website. Here's my reference, and pulled some stats for you about marijuana as well, just to give you some objective information about marijuana that is backed by medical studies. It has been found that smoking marijuana is bad for us. It contains many of the same toxins, irritants, and carcinogens as tobacco smoke. In other words, if smoking tobacco is bad for you, smoking marijuana is probably going to be bad for you too, because it has many of the same bad chemicals. Now, there are differences in smoking methods between someone who smokes a joint typically and someone who smokes a cigarette. And more explicitly, someone who smokes a joint is looking for a high. So they'll inhale more deeply typically, and typically hold that smoke in their lungs for a longer period of time. And due to those differences in smoking methods, a typical joint, or marijuana joint, will expose the lungs to more tar than an average cigarette. Finally, secondhand smoke from marijuana is also going to have many of the same chemicals or carcinogens found in that primary smoke, or the directly inhaled smoke. So in other words, just sitting in the room with someone who's smoking marijuana is going to expose you to many of the nasty chemicals that are present in marijuana. You can see this sometimes when somebody that's been hotboxing in the car will have a friend come in and they'll try to inhale the smoke to get a secondhand high. Smoking marijuana has been shown to lead to chronic cough, phlegm production, wheezing, and acute bronchitis in patients. And to summarize the American Lung Association's position, the American Lung Association strongly cautions the use of marijuana in addition to the use of tobacco products. So, class, concept check here. What is the disease that is characterized by the alveoli of the lungs filling with fluid? You can go ahead and rewind the video. You can pause it, check your notes, check your PowerPoints, check your text. Please get me an answer. 5, 4, 3, 2, 1. A disease that is characterized by the alveoli filling with fluid is B, pneumonia. And that's all we have for this presentation. If you have any questions about the material that was covered in this recording, please feel free to shoot me an email, post them on the class discussion board, or stop by my office when you are on campus. As always, happy studies.